to have such a talk because we are going into the essence of the seminar, because we use electro and cryo modalities in an interchangeable way in order to achieve our goals, which are to take sufficient diagnosis and diagnostic biopsies, but as well treat our lesions with therapeutic purpose. So, of course, we know that we can have central airway obstruction due to malignant or benign causes, and sometimes due to the technical difficulties, we can have even a benign lesion that can be even more difficult than dealing with a malignant as regards the airway obstruction. Most importantly, what we need to focus is on where is the lesion. Do we have an intrinsic stenosis, so our lesion is inside the lumen and we can completely remove it with our tools? Is it extrinsic stenosis, where the lesion is completely outside of the lumen? We just see that the lumen is bulging and we cannot really take sufficient biopsies with our tools. Or we have usually a mixed stenosis, where we have intrinsic as well as extrinsic issues, and then we have to decide about which technique we should use. I have given you here some examples from our practice. You see that histology is not very important as regards what endoscopy looks like. So usually we have a picture of exophytic growth of tumor, as well as necrosis, as well as extrinsic pressure and submucosal infiltration. And of course, in many malignant lesions, we have neovascularization, so we have bleeding diathesis when we start with the biopsies, as you see, especially in the middle image. So, not everything is a carcinoma. We can have quite bleeding lesions. We can have a bulk lymphoma, as you see on the left, or a carcinoid. Carcinoids are notorious for bleeding, so we need to be very efficient with our techniques in order to get biopsies or even remove the whole lesion without causing significant bleeding to the patient. And we can have some hamartomas, which are also quite bleeding, as you can see in the right image. The stakes are high, meaning that we have to be very efficient with our biopsies. We need to have a diagnostic level of 85% when we are dealing with endobronchial tumor, when we have these lesions inside the lumen. So there are not excuses. We have to be very efficient with hemostasis and get sufficient biopsies. We take at least 5 biopsies from an endobronchial tumor to maximize our diagnostic yield, but we also combine our techniques with the cytological techniques, such as brushing and washing. This can add up to our diagnostic yield and should not be neglected, even if we have sufficient tools and sufficient technique to get this endobronchial biopsy. So always we take the cytology, we take the brush, and we take the washing as well. The stakes are high because now our oncologists need our molecular markers, and usually they need the molecular markers at a great level. They do the NGS, the next generation sequencing, which has evolved and needs less tissue, but nevertheless we have to be sufficient, and we should not get back the result and saying that we were not able to do this approach. We should be efficient because we also need, in many cases, PD-L1 testing. Immunotherapy, at least in Greece, has been introduced in the first level of introductory treatment or oncologic treatment, but nevertheless, when we have this information, we can be more sure about our therapeutic response. So this is something that is done with immunohistochemistry, so we need to provide at least viable tissue to do this. We also have to be sufficient because our oncologists now rely on us for rebiopsies. Many patients take molecular treatments or take immunotherapy, but at some point they stop responding to their therapy. So especially for molecular therapies such as EGFR, we need to take new biopsies because they have second-line treatments that can be given when we observe this resistance in a tissue. So we need to be efficient with our patients. And of course, everybody here knows that when we have a patient that we do a bronchoscopy on a patient that has already taken oncology treatment or even radiotherapy, things are more difficult. Bleeding diathesis of the tissue is much worse. So these techniques are even more relevant in these patients. So how can we proceed with efficiency and safety? We use these tools for the hot techniques. This is a combined electrocautery and APC machine. The versatility of this machine is very important because by the press of the black button, with our feet, we can change the mode from cautery to APC, or from coagulation, which is usually programmed in the blue setting, to the yellow, which is a cut mode. The cutting mode is usually in therapeutic bronchoscopy, but it can be used to deal with aggressive bleeding, and it's very efficient. This is a very new tool, as you see in the picture, and can be programmed according to your needs. So you can have specific programs with specific energy given. We don't use setting of VATs anymore in the new machines. You can really program what you need, the soft coagulation or more rapid fire on the APC in order to deal with aggressive bleeding, and all can be changed with this black button. Differences between modes. Electrocautery. Electrocautery is a contact mode, so we should be able to touch the mucosa. Heat is created through electricity. When we conduct this electricity to the tip of the probe or the tip of the forceps, then electricity passes through this point, and thermal energy is created, and then all this energy dissipates through our grounding. It's not a grounding, actually, it's a 0 point. We use this this thing we put on the legs of the patient. It's the way of the electricity to dissipate and the thermal energy to dissipate through the body. So it is, of course, always important to have the patient grounded, as we call it, but it's not actually grounding. It's a 0 point where the heat and the electrical energy dissipates. We can use various tools. We can use the knife, the probe, the forceps, the snare. The snare is very important for lesions that have a small bud. And we have a relative contraindication. When a patient has a pacemaker, we have some risks. Electrical energy passes through the body of the patient very near to the heart. So we have to take into consideration two aspects. The first is that if there is a pacemaker, then the grounding, in brackets, should be on the other leg, which means the right leg, in order for the electrical energy to dissipate to the right. And the second important thing is we have to be aware that the pacemaker should be set on a standard point. So it has to be set on a 70 beats per minute, for example, because if by any way the modulated rhythm of the pacemaker is disturbed, then the basic rhythm still keeps on. Because some patients that have a pacemaker do not have a basic rhythm. If the pacemaker is disturbed, the heart stops beating. So this is very important. Usually when we have such a case, we have a specialist, a cardiologist, with his machine ready to modulate the machine. We set it on a ground level of 70 or 75, depending on the patient. And if by any way we have a disturbance, he has to be ready to put a temporary pacemaker. Why all this? Because the alternative to the electrocautery is a laser, which is not doing exactly the same thing. It's not available in most interventional pulmonology units. It's very expensive. It's not easy to have a machine just for some patients that have a pacemaker. So we can do it with patients with pacemakers, but we have to take precautions. Let me show you an example of the snare. The snare needs some training. It has some learning curve. It is used for lesions that have a bud. So we can circulate the lesion, as you see here with these movements. We try to put all the snare behind the lesion. And then we ask our assistant to start closing on the bud. And then we push our pedal and we start to cut slowly, trying to keep all the lesion inside our snare. And we cut and we press, we cut and we press till we have a chunk coming out. And then you will see that we can take this piece out. Even if it is cut and it stays there, we have to be quick, take out our snare, put a forceps, and take it out with our bronchoscope, because usually these lesions are larger than a bronchoscope, so we have to remove it. It's easier when we have general anesthesia, tracheal tube, laryngeal mask, because sometimes if we are using conscious sedation, we can lose the lesion in the larynx. So it needs some training. If we are not sure, if we have conscious sedation, we can use the snare. But if we are not sure that with the snare we will be able to pass through the mouth, it's better to leave the lesion there and have the patient really well sedated, not to cough, because then we will start looking for it in the contralateral bronchi, and then take it with the forceps and take it out safely. So this is the way to do it with a snare. Requires some training. APC now. APC, as you see, is a non-contact mode. We are spraying the plasma, which is actually ionized gas. It's argon gas, which is ionized, reaches very high temperature as soon as it is expelled through the catheter and burns the tissue. So we spray argon from a 2 millimeter distance, and you will see this in the hands-on. Why we do this? Because if we are in complete contact with the tissue, first of all, it doesn't work well. Second, if we release huge amount of gases on a tissue that is very well vascularized, we risk the argon going into the vessels. And then we have this reaction that's called argon embolism, air embolism. So these molecules travel to the brain, create some infarcts there, and we risk having our patient not waking up or having not waking up properly or having some difficulties to move. Usually this is transient. In a few hours it dissipates, but it can be really bad for the patient. Maybe he needs to be in under general anesthesia till this dissipates. So this is a very useful tool for bleeding mostly. The newer modes that the machine that I showed you has can cause really coagulation of the whole lesion. So if you have a really vascularized lesion, we can spray it with the argon and then start with the biopsies or even cut it with a snare. Especially applies to carcinoids. So it's a very useful tool, and since we have it in these new machines, interchangeable with the cautery, we use it a lot. Very important, very important for argon. The most important complication of argon is to have an endobronchial fire and damage your scope. Usually when we have an endobronchial fire, it's due to high FiO2. So when we use the argon, usually we lower the FiO2, or if we have the patient on the ventilator, we take him off altogether and wait for 2 to 3 minutes till we have a dissipation of the high oxygen concentration, and then we start with the argon, because the most important complication is to damage your scope. Okay, and it's not very difficult to do that. Our rigid technique, we have electrocautery incorporated in the rigid scope. You see here quite a big lesion that is cauterized. The probe of the rigid scope is much more efficient and takes less time to cauterize and completely destroy such an exophytic lesion. We usually combine this with the technique of debulking, as you can see. So we use the bevel on the left side. We see the bevel of the rigid scope after cauterizing the lesion, using this cutting mode and moving in parallel to the axis of the bronchus, and we cut the lesion and we try to take it out with the forceps afterwards. And of course, afterwards, when we have removed, you see the forceps is moving, and at the end, when we have removed big chunks of the tissue, then we cauterize the bed of the lesion for hemostasis. Benign lesions can be quite bleeding as well. As you see here, a carcinoid that has completely obstructed the bronchus, and we cauterize the lesion, which is, as you see, it's moving a lot, but it's bleeding a lot. And an important sign is when we have removed parts of the tissue underneath, we can find this picture where we have pus. So if we see pus coming out, and here you see we try to suction it, it means that the obstructed atelectatic parts of the lung can expand again, and usually we can have back this pulmonary segment. So, and a very important thing when we do therapeutic bronchoscopy is to find our tract, and if we find under the tract that there is pus coming out, we can be more confident that indeed we will find a more healthy bronchus underneath. And of course, we use the APC to cauterize through the flexible scope as well. So we use rigid and flexible techniques at the same time in therapeutic bronchoscopy. Cryotherapy. Now, cryotherapy is a very versatile mode. We use this probe where we throw nitrous oxide through it, and due to the Joule-Thomson phenomenon, where when we have gas going from the gaseous state, it is converted, going through the small orifice to a larger place. This change of volume and pressure causes the gas to go into very, very low temperatures and causes freezing. So we reach minus 40 degrees at least. And we use this on the tissue to have two different effects. The first is the early effect. When we rapidly freeze, we create the intracellular ice crystals, which completely destroy the cells, cause the cells to swell, and we have tissue necrosis. So we take advantage of this. The late effect is that this continues, and even if we could stop the cryotherapy, this is prolonged for 2 to 3 weeks. So cryotherapy has also a late effect. It's not something we do in an instance and it stops working. It works throughout the next 3 weeks and can create a very prolonged effect on tissue. So we have two techniques. We have the conventional technique, which is we slowly pass the cryoprobe with freezing and thawing circles, millimeter by millimeter, and we try to apply this cold technique on all the tissue, and this can have this prolonged effect up to 3 weeks, as we discussed. And this is the conventional technique. So each millimeter of tissue is applied and treated for 1 minute approximately circles. And we have the second technique, which is the cryo-extraction technique. Needs a little bit of training. We identify the lesion. Let me show you an example. We freeze at the base of the lesion, and we freeze for 3 to 4 seconds, and then we extract the lesion together with the bronchoscope, as you can see. So we start here. It starts with the freezing here. We have the base of the lesion, an exophytic lesion, necrotic at the end, and then we pull slowly, and we take it unblock with the bronchoscope. We have to be very quick to thaw and take all the tissue out, and then we get in, because usually the base of the lesion will bleed. So we interchange with our hot techniques, and we coagulate the lesion in order to have good results. We can do this technique through the flexible scope, and it's very efficient. You see here in the study that they have a very good result, up to 91% in big lesions, and they did this cryorecanalization with a flexible scope through a tracheal tube. The technical tips: we have to reach for the base of the lesion, depending on our possibilities. We touch the tissue, not the mucosa, which is surrounds. So if we touch the mucosa, the bronchus, we just leave it to thaw and we try again. We do not push, because we will cause unnecessary bleeding. We control the hemorrhage, and we aspirate necrotic material. Of course, we do not remove the cryoprobe before it is thawed. So we do not push the cryoprobe when it is frozen, because we can damage the scope. Some points on hemoptysis. There are many causes of hemoptysis. I will not go into details. I just want to stress that up to 20% remain cryptogenic, but still we need to know how to deal with it. First, we set the patient on the bleeding side, and so thus leaving the healthy lung on top. And then we use some balloons, endoscopic balloons, which are very important for dealing with the hemorrhage. On the right side, you see what we use most. So we pass it through the scope, but even if we have massive bleeding and we cannot do this, we have this Y-shaped also blockers that can be put on the main carine, and then we can either inflate the right or the left side. Okay. So I will skip the thrombus, and I will just give you a last slide. We use these techniques a lot even for foreign body removal, because we can use the cryoprobe to remove biological foreign bodies, as you can see on the top slides, but also for removing, this is one of our cases, a little bone that caused huge granuloma malformation on the bronchus. So we used the cryoprobe to take out this bone, but also treat the granulomas afterwards, because the cryotherapy is a very useful technique for treating the granulomas in a mild way. It doesn't cause new granulomas, and it's very beneficial for the tissue. So with that, I would like to thank you, and have a fun trying this on our models as well.
Okay, thank you very much. You covered some of the topics of the next speakers, but I think that we will manage